So this topic is very close to my heart. I'm going to share my journey. And also kind of, since many may not know Mount Sinai, it's other side of the river, I thought I'd just give a little bit a background of where I work and what our priorities are. So we were founded in 1852. We are now a 7-hospital health system, integrated delivery network, around 7,000 physicians. And our famous saying is that within 1 to 2 blocks of any resident in New York City, our facilities are there. But this is our burning platform. And I want to start at this kind of a notion coming from a hospital, which typically are the major revenue maker, but we are deeming a hospital as a cost center. We have this big advertisement: if our beds are filled, that means we have failed. Basically, we have a whole organization set up to say how we transform to a value-based healthcare, where hospitals are not at the center for healthcare delivery, but actually everything outside the 4 walls of a hospital are major part of healthcare delivery. And it's like preaching to the choir here. I think there was a lot of good conversation on value-based healthcare, but this is probably the most underread and underreported health report that anyone has, not paid heed to. So 50% of all the payment from CMS by 2018 will be based on value-based contracts and not fee-for-based contracts. And if you know the profit margin for any hospital, 5 to 7%, right? And if you reduce 50% of payment coming to the doctors, most of the hospitals will go into red. And it's not a surprise. Last year alone, the bankruptcies of health systems tripled just because of shift to value-based healthcare. And the fact that we as health systems, we as practices, are completely unprepared to transform to value-based healthcare. 3/4 of the 5,500 hospitals lost readmission penalties for CMS. And 50% of practices, health systems, are actually unprepared for all these MACRA MIPS, not to talk about ever-changing rules for the MIPS that are coming. And just to share some of the losses we are having as part of Mount Sinai, so we lost $1.5 million 2 years alone, just on CMS readmission penalties, right? If you expand it to programs outside CMS, to Medicaid district population and commercial payer, and you to look at increasing incentives or penalties, we will be losing around $100 million a year in the next 5 years if we don't transform our strategy. So this trade is real. And if we don't change ourselves, very soon this is what's going to happen to all of us. I'll let you read that. Right? So we really need to change. We really need to change this triple whammy and make it much more palatable for us as care providers and patients, because we both deserve better. And my single most important plea would be, we have to really stop looking at EHRs alone. EHRs are technology that came 20 years ago. And what it has done is create such a narrowed framework for us that we believe the only way to deliver care is through electronic health record. While electronic health records was predominantly made just for transactional care when a patient meets the physician and you drop a code or legal record. But most of the things that value-based healthcare needs is not transactional records. It needs a longitudinal way to engage patients, right? And 99.9% of the time, when you're going to change a behavior or have an action being taken by a patient, they will be at their home or at their workplace, not sitting next to you, right? And I'll give an example of Steve Jobs. There's a very beautiful documentary around 20 minutes on Netflix where Steve Jobs, he says it's not a geek, but you will see how much geek he was, where he says in 7th grade he read a book which compared the efficiency of locomotion among all the species in the planet. What does that mean? Basically, that means how many calories people and all of the species on human planet burn per mile walked. And humans were very inefficient, maybe after tortoise or something of that nature. And then he read and he said, oh my God, this is so depressing. We humans are so inefficient. But the next chapter was very optimistic. They put the human on a bicycle, and suddenly humans became the most efficient species on the planet. And to Steve Jobs, computers are like bicycles of the mind. They don't change the direction you want to go. They don't change the aim, but they help us become so much more efficient than had ever been possible before. And this is what we see digital medicine as bicycles for our mind for value-based healthcare transformation, right? It allows us to do things which were never possible before in a way that we never thought was possible. And I'll give you a few examples. I was doing telemedicine when I was in Cleveland Clinic in 2002. This was a $75,000 Cisco equipment. I was in a room I had to go, and there was a nurse which was 15 miles away, where employees of the clinic used to work, and they used to be roomed in that room. Yes, that was telemedicine, but it was logged into the same space. I had to report somewhere, patient has to report somewhere. And look at just the camera of a smartphone. Each smartphone now has 1,000 times more power than all the NASA supercomputers combined in 1969, which led the man on the moon. I'll rephrase that. We were able to achieve something in 1969 which we never thought was available, mostly because of all the supercomputers. You multiply by 1,000 the power, and each one of our patients now have that power. Only if we can unlock that, we can do things which we never were able to imagine before. And I gave an example of camera. Let's take example of Bluetooth, which you just use basically to listen to some good music, right? But Bluetooth in the smartphone had completely unlocked the field of Internet of Things and wearable devices. Now you can track what your patients are doing, how much they are sleeping, right? And anything that you want to know if patients are willing. In fact, there's a $75 mat, and you put in nursing home, you can tell that how long the person is sleeping and how long they are awake. And if they start sleeping more than usual, you can create an alarm which can trigger that this person is probably going south in some regards. As part of our app lab, we do an app landscape. We look at all the technologies that are coming and which ones are worthwhile to bring into our health system. So if you really look at the app landscape, there are more than 325,000 medical apps right now in iOS and iTunes. 325,000, right? And out of that, only a fraction of the one which can really be a game changer, which really allow patients to be connected to the physicians. I'm going to give few examples of worthwhile apps and tools just to anchor how far the field has gone and how we can leverage. Velduck was the first app that got FDA approved. Before that, FDA did not even have people to evaluate a software program. They had to convene a special body of consultants to know, can FDA approve a software program? But they really showed the results. Within 12 months, they were able to show an HbA1c an average sugar reduction of 1.2%, which was exactly the same as a $1 billion drug that came to the market by FDA 1 month ago, right? So this ushered the field of digital therapeutics that you do not really need a new medication. We have enough medications. We have enough devices, enough kind of surgeries. We really need to optimize our care delivery. And if you can do that using latest technology and remote monitoring, we can achieve miraculous results. And all this was doing was capturing sugar through a smart glucometer, giving to an AI platform, and suggesting to the patient's back to say how much they have to titrate their insulin. The issue of the telemedicine came before, but many do not know that majority of the states in the United States now have a parity law approved for telemedicine. What does parity law mean? What that means is not only CMS is going to reimburse for the services, but most of the commercial payers are now bound by this parity law to pay at least something for the services. Now, instead of picking up a phone call, which nearly is never reimbursed, you can dial and have a telemedicine call, which will be 70, 80 times reimbursed for the right patient mix. So you can actually add revenue as part of that, increase access without much penalty. And I talk about telemedicine is like water. The cost of implementing telemedicine is close to zero now for a larger practice. And not everything has to be video visit or an app. Just secure messaging platform, if we implement in the right way, that can be game changer. This is a very fascinating study published from Australian researchers in JAMA. And what they showed was only 4 text messages, one directional text messages to patients, reduced the smoking cessation rate in patients with heart disease by 40%. This is more than all the 3 FDA approved medications combined that can achieve. That's where the field of digital therapeutics is going. And I'm not saying not just 2017, but 2016 was considered the year of wearables. We are way beyond that. 50 million wearable devices were shipped. Now FDA has approved the first wearable or a sensor that actually will go into a medication and can track not only when a patient has taken it, but when a person has pooped it out. I'm a gastroenterologist, so I talk about poop all the time. But this is where technology is going, right? Abilify, for a schizophrenic patient, you can track how often they're taking the medicine and give them alerts. And it's not just the technology alone, the technology, how it comes together really makes the magic happen, right? So I often give this example of Cymatics, not because I have endorsed or have bought the shares here, but just how fascinating it is, where there's no good biomarker for smoking, right? You have to take a blood test if you really want to show the person has stopped smoking. But what if we can predict the person is smoking real time using a band which knows and the position the person makes. So you can distinguish if a person is smoking or the person is combing the hair or eating food just because of AI, which can say how the position of the hand is working. And then not only you can do that, because you have GPS there, you can tell a person, it seems like you are at Mount Sinai Hospital and you just worked with Ashish Atreja, so that's why your tension is much more and you have to stop smoking out there. Right? So really what we are seeing is all these technologies move away from this crazy West Coast quantified self movement, where you kind of give your saliva to stool to quantify them on genomics, to very fascinating business savvy East Coast people, which can now do quantified population health and do value-based healthcare transformation. So if you really have to fast track ourselves, based on where you are, it could be Vision 2020 or 2022, where you will see virtual care, remote care, telemedicine becoming mainstream. In fact, there's already a prediction that you'll have more digital touch points with your patients using these technologies than in-person technologies in majority of US by 2022. You'll also see predictive analytics not based on payer data, which we talked about in the previous, but real-time predictive analytics based on how the person is doing right now. Because right now you can predict, in the current scenario, which patients are at the highest risk. But really those are 5% of the population. And that is a dynamic list. What you really need to know is which patients are rising risk, which are gonna make up to this new pool. And there's no way right now, looking at the payer data 3 months ago, to know which patients are gonna get admitted because they are uncontrolled right now. Only if we turn on remote monitoring, you can track the entire population at once. And there was a very good discussion on social determinants of health and how to capture that. We're gonna see mainstream. And the challenge we had with our EHR, they don't even have fields to do SDOH. So you have to capture and store the data somewhere else till the EHRs get ready for that. And then I'll bet to you that we're gonna see prescription of apps, prescription of digital therapeutics becoming as common or more common than the medicines we prescribe. But how do we get there? I mean, this all seems great, right? It seems like a great pitch and kind of a lovely thing, but I'm gonna share some story. We have to build our capacity internally within our health system to get there. I'm share some examples of what we started 5 years ago at Sinai. And this is our concept. We looked at all the major digital medicine technologies and said, how do we create a unified experience? And we came to this concept of a digital daisy, right? So to a patient, it should be a very good experience. They don't have to see all these complex technologies, AI, machine learning, blockchain and all. They need to have some digital gateway and everything gets invoked based on the patient's need. So this was a mission that was given to us in our app lab to build new technologies, to test technologies from startups, and then bringing it all together in a way that allows our digital daisy dream to come true. And really, there was a message which Shahid was giving earlier on that there should be no programming without a clinician being involved. And that was the single most important asset we did. Our center is based within a health system, and it's not just we have user designers, data scientists, and developers working with us, but actually the real benefit is all the collaborators. So we had 25 plus funded projects over the last 5 years in every specialty of medicine. And every specialty of medicine, we learned from them. And then we look back and say, how can we do better on what we have learned from this specialty versus that specialty? And we worked very closely with our tech transfer team, our population health team, and really looking at all the providers in specialty, the patients across the 7 hospital health system, our pop health and ACO, and researchers who come with very bright ideas, and making an ecosystem where we can test out new things. And this is where our journey got started. So being in GI, it was logical for us to see what are the gaps in inflammatory bowel disease patients, patients who have a lot of stool with bloody diarrhea and very bad poor quality of life, around $30,000 cost of care per year. And Mount Sinai has one of the largest IBD centers. In fact, Dr. Crohn's used to work there. So we have a legacy that brought me from Cleveland Clinic to Sinai. So we started this remote monitoring in IBD through using an app. And the main reason was 50% of the patients who were coming to us for surgery, we felt we could have prevented their surgery if we had known 3 weeks before that the symptoms were getting worse. But most of the time when patients were coming to us in ED, we never had this opportunity time to engage. They had to go to surgery. So we created a real app which will track the patients, and we get the data back using a dashboard linked with electronic health record. So for the first time, we had a finger on the pulse on nearly every IBD patient. And the data comes back and that gets automatic triggers of which patients are falling through the crack. So we can engage proactively with them. And we were able to show within 6 months, you can improve quality of life of this very tough population. And you can increase all the quality metrics. All these quality metrics that are very painful for us, for PQRS and all these MATRA and MEPS. What if instead of you as a provider measuring those quality metrics, you give the toolkit to the patients to measure it, right? Patients are 94% accurate in most of their quality improvement metrics. And not only they measure it, they get an incentive to improve on it, and you use them to improve, and where they're falling through the cracks, then you engage. So we showed that model to be fairly successful. But as with this new technologies, you start getting new data, which we were never exposed to. And this is very new data for a gastroenterologist to absorb. So I was presenting in our Digestive Disease Week, this conference, and said, we compared our data with UPMC data from Pittsburgh. Think of Spanish Harlem population, real-time data coming from an app, compared with a paper-based data collection over 5 years in rural Pennsylvania, right? 10 domains of quality of life, exactly the same pattern. Exactly the same pattern. And what is more unique about the pattern is the number 1 and number 2 predictors of poor quality of life in these gastroenterology patients were not GI symptoms, right? They were anxiety and pain. They were psychological symptoms. So when I presented to our conference, I said, we as gastroenterologists are really missing the mark on how to take care of our patients, because this new data is real-time data. And gastroenterologists being gastroenterologists, they came back, they say, Ashish, you are missing the point. We are doing such a great job that there's no more GI symptoms. The only thing that's remaining is the things we are never trained to do is how to take care of the behavioral medicine people. I said, fine, your point is well done. So we started to create a whole digital medicine toolkit that how do we bring the best of behavioral medicine and other technologies to the gastroenterology world. And instead of building one more app and contributing to the noise, there are already 325,000 apps. If we make 15 apps, we are contributing to the noise. How about we start to decrease the noise by bringing all the most evidence-based technologies, whether it is in cardiology, cancer care, chronic kidney disease, GI, together on one platform, right? And not only we bring apps into that platform, how about we combine all the digital assets which are there, right? Which means how do we take the best of patient aids, patient decision aids? How do we take the best of video education? How do we take the best of patient-reported outcomes, right? And put it all together, and the variables, and the appointment scheduling, and really turn on for every single initiative we have to do at Sinai. So we tested it out last year, and our goal was we'll turn on our app prescribing platform. And we tested, we never knew our care team will deliver it, patients will click on it. We said if in 8 weeks, we can prescribe apps to 100 patients, my mission is done, and I'm gonna retire. So, I didn't get retired. And the reason was we ended up prescribing to more than 2,000 patients. So now I was told to launch it health system-wide, which is another part of our very big success story. So we did further validation that how easy it is for providers to train on these new tools. Remember for EHRs, the training you go through, right? So 3 to 4 days training, full-time training, we took 5 minutes training of the care team people, and we got a 96% usability score. Because it's so easy if you make things intuitive. And that's the power of digital medicine. We were never at the table when EHRs got designed. So someone pushed EHRs to us. But in this technology, we have an opportunity to design things on our own, in a way we want to do it, in a way we want things to reach to our patients. And remember our thing about gastroenterologists, not knowing anything about behavioral medicine? So we worked with our cancer behavioral specialists, created an app for meditation. And now we trigger this app automatically if a patients are falling through the gap on anxiety. And what's best, Deepak Chopra reached out to us and they said they are making a new app for meditation for free. So we are invoking Deepak Chopra's, which could be much better than mine, and give automatically to gastroenterologists. Suddenly a gastroenterologist who's never trained on psychiatric can actually have at least some of its population being intervened by digital therapeutics. And then we extended our framework to put devices on the picture. So we partnered with a New York City startup called AdhereTech to track medication adherence. Now we're launching medication adherence as a service, which will automatically tell if patients are taking the medicine at the right time or not. Our initial use case was $70,000, $80,000 hepatitis C medication over 12 weeks, very expensive. Wanted to be sure we are able to do a good job with that. And then we extended to all these Fitbit and Bluetooth connected weighing machines. So this was our heart failure readmission pilot project we just presented in American College of Cardiology. We were able to show 50% readmission reduction in 30 days. Not because of any magic, just by the ability to connect what patients were doing before they got discharged, and then having a wearable device to them so we can trigger them if their blood pressure got increased, if their weight got increased, or if the symptom got worse. Just by connecting at the right point with our care team, we were able to show a very magical decrease in the readmission rate over 30 days. Talking about SDOH, one of the things that came to us is it's so tough to capture SDOH data from EHRs. They don't have fields. So we looked at Prepare instrument. It's a nationwide instrument. And we modified that instrument for us. And now we're launching a Mount Sinai Health System-wide. We prescribe SDOH as a toolkit to patients who come to us. And the data comes back linked with EHR. So any provider can see where they are actually not doing good. Now our next goal is to connect with things like interventions. And directly, if they are lacking on transportation, we connect with Uber Health or we connect with Lyft to kind of offer those services. And really the magic is get the data back, but link it with the intervention. And I'll share one example of that because that service recovery intervention is where rubber meets the road. And just if we turn on technology, but we don't pay heed to the process and people, nothing really happens. It's just shiny technology that's just sitting outside. So we did a small pilot in one of the units. We have all press Genie, right? But press Genie happens after the fact. The person has already left the hospital. What are you trying to do at that point, right? And it's only the most disgruntled patients get back to you, the 20-15% of the patient, not the entire. So we turned on a patient satisfaction instrument while the person is in front of you, admitted, or their caregiver. We got 98% response rate getting the data back. And more importantly, not only we got the data back, we were able to real-time show the data to nurse manager, intervene on the data, so patient, by the time they left, they were very happy, right? So that's exactly what you want to do. You really want to turn on interventions exactly when the data comes, not later on. So this shows our patient experience survey, which we were really lagging behind. We were able to increase to 85% of physician communication just by closing that loop. Now we're working with our cancer experts on oncology care model on how you bring the same kind of technology and patient decision aid. So this is just one example where real time, if a patient or physician enters, what are the parameters for your cancer, how many lymph nodes and what have you got involved. It will match to a 50,000 patients database and will give a real-time scoring. You should go with surgery directly or a surgery before chemotherapy. So you can allow much more complex decision to be taken, but based on grounded evidence. And a lot of need came to us that, hey, value-based healthcare is just great, but we're not there yet. Most of us are still fee-for-service. And so we got a need that how do we take care of things which really require a lot of operational throughput, like colonoscopy, like all these surgeries. The OR time is very precious. And how do you optimize that? So we worked on, based on needs from ENT, cardiothoracic, GI, we were able to pool all of them together and create a Procedural Toolkit. So patients before a surgery will automatically get customized alerts based on the date and time of what needs to happen to them, a video education about that procedure. And then, hey, by the way, you are in New York, so these are the driving directions, these are subway directions, and this is the cheapest parking spot available close to us, right? And then post-surgery, it automatically follows up. Talking about the MIPS, care coordination, I know the discussion that happened before us. How about you automatically trigger a message that goes to the patient to say, hey, you had a surgery yesterday, this is the time just to to be relaxed. And by the way, did you get a chance to fill your medications? If not, you connect with the nurse at that point. And if the symptoms are worse, at that time, you invoke telemedicine real time, because that's when the person really needs telemedicine, and you prevent an ED visit. So from our side, we have partnered with a few other academic centers as well, and looking for more partnership in the area to say, bring your own use case to us, and we'll work together to see how we can solve it using digital technologies. Now, of course, there are certain things we cannot solve, but those becomes kind of a thing for us to shoot maybe next 1 to 2 years as technologies evolve. But there are many we can solve. And the other part is most of them will link with a value-based healthcare, right? Either it increases the operational efficiency or it provides automatic quality improvement activities for MACRA and MEPS, or it aligns with our pop health initiatives for 5 most expensive diseases, or it really enables us to do at-risk ACO and bundles contract, right? Because if you just turn on technology, there's always a need for these technology, but they were not business use cases before, right? So technology was not being used because it was not helping us increase revenue or decrease cost. But now with value-based transformation, we have alignment with the business cases as well. I want to be sensitive of the time out here. Are we doing okay for next 15 minutes? Perfect. So that shows I'm speaking very fast. So, but there's one thing which we cannot solve, you cannot solve, which we all have to solve together. And that is, what is the thing that's working among all this noise, and what are the things which are not working? And that's an ecosystem challenge. That's not one innovation center versus other innovation center. If you look at digital health investment, this is the first time $6 billion investment was made in a year just on digital health technologies alone. And what it has done for us, it has created some good solutions, but it really has created a problem of plenty for us. There is so many companies, there's so many technologies that we have decision paralysis on what to go for, right? And that's what we do not want. We do not want companies which are not based on evidence, which are just like, in fact, today, if any company comes to the CIO that we do this, the first thing which a CIO or its team does, they go to the website of that company and then decide, oh, we should interview them. Nothing can be more biased than seeing a website of a startup company, right? I mean, it's like we have to get a medicine into a formulary, and instead of going to FDA, we just look at the website or look at the pharma rep and say, oh, yes, you're a great pharma rep. Let's get your medication and prescribe to our patients. That is what we are doing in digital medicine. And we need to really do a better job than this. And sometimes it's bad intention or lack of good intention, which leads to, like Theranos, which leads to bad companies. But sometimes the intentions are good. The technology is good, but the processes are not good. So Eric Topol, who many of you know, is the first dean of digital medicine. Dean of digital medicine, yes. Digital medicine is now a specialty. In fact, it's considered a specialty that underpins now most of the specialties in healthcare. And this dean did a remote monitoring trial, used $1.5 million of technology to remotely monitor patients with diabetes, with hypertension, and with AFib to see over 6 months, can you increase patient outcomes and actually decrease the cost of care? And the results? Absolutely zero improvement in outcomes. Absolutely zero, right? And the reason was, this came not from clinicians. This came from a payer system which reached out to patients separately and say, hey, we have a very fancy trial, recruit yourself in the trial. So patients were not engaged in their day-to-day care, right? And if they don't know it's coming from the care team, what we have learned in our thing, if a researcher engages with a patient, but it's not with the care team, you see 30, 40 to 50% less benefit because there's no internal motivation that things are gonna improve. And that's what exactly we saw in this trial. But healthcare technology is really fascinating. Things we think will make an improvement in outcomes does not, and things we think are just game start making improvement in outcomes. So Pokemon Go is considered the biggest fitness craze, the best fitness app in the world. And I never thought of that till my kids, we were having a backyard party and the kids approached me and they were running all over. And I said, wow, see, the kids are just wonderful. And my son came to me and he said, Daddy. I said, what happened? He said, Daddy, you never told me there's so many Pokemon in our backyard. We're just chasing the Pokemon. I said, wow, we adults need to get this thing, and so we can chase, and we can be much more positive in our health behavior. So we really have to test technologies because sometimes there will be technologies which we don't feel are good. They may be at the periphery, but they may be the biggest game changer for us. Till we test it, we'll never know. So we need to take all the innovation a lot of the community here is doing, really have to combine with the evidence-based knowledge, which a lot of us are trained on. And we need to create together a new science, a science of evidence-based digital medicine, a science we can trust, technologies we can feel comfortable prescribing to our patients. So we started a whole consortium. Now it's turned out to be a foundation, a 501c3 called Node Health, a network of digital evidence in health. And our goal is first to share information about each innovation that health systems are doing. And the reason being, we health systems really lack the capacity to test out all those technologies. And we are duplicating each other's efforts doing the same pilots on telemedicine. The time for telemedicine pilots is gone. We can learn from each other and rapidly actually do in our care transformation. But we're not sharing because we believe everything that is innovation is an IP, right? We feel innovation is equal to IP, and nothing can be further from truth. We looked at most of the projects we are doing, 90% of the projects we are doing we had no IP at all, but still we were not sharing at all. So the second goal is to standardize policies. How do you do business assured agreement? How do you do security governance for these apps, right? It has taken us 9 months to do security assessment for an app company. If you can standardize practices, and if Hackensack does it, I don't have to do the same security policy with some kind of like a smart IRB kind of a thing, we suddenly become much better in evaluating technologies. And then, why should we test the technology which is breakthrough, just in a small pilot? Why don't we do multi-site, kind of a pivotal trials? And then let's have 2-3 health systems say, this is really game changer, and then turn on transformation across the health system. So we have to solve this evidence challenge together. And really the second bigger challenge is transformation challenge. Telemedicine has solved the evidence challenge. There's enough proof for that, but it hasn't solved the transformation challenge. That's why there was no answer when I asked the telemedicine question, because we have not learned the implementation science of how to implement telemedicine and the right kind of use cases when to invoke telemedicine to make it useful for us. And that's a transformation challenge, not an evidence challenge. So this is kind of our concept for Node Health. This is a figure that where health systems and patients are in the center, and then we work very meaningfully with all the major stakeholders in the area, including industry, including startups, including government. We started in a very small kind of a happy hour. You know, the best way to bring people together is to give some booze. So we got people together, and they were under effect of something, and we got them okay on starting this foundation. So, and that has really gone great. Now we have 25 health systems. We have a formal executive board of each of the health systems working together to share the best practices and learning from each other. These are some of our consortium members from West Coast, East Coast. And one of the most interesting thing that happened is we have most of the New York City competing hospitals part of this consortium, right? So just to show that we can work together in innovation space, and we don't have to be shy and just shielding all the innovation from each other. And also what's really great, we have major partnerships now with ONC, Academy Health, American College of Cardiology, NJII, and PCHA. So all the major ecosystem groups which are supporting digital medicine, we have partnership with them as part of Node Health. We launched an Evidence Pulse, which now goes to 6,000 people community. And this is the first peer-reviewed newsletter in digital medicine. We curate the evidence, and we don't just publicize what's there. We actually look at what's published. So our goal is published instead of publicized. We're also very happy we got a digital biomarker journal, because if there's a great innovation story, we want to publish and make it available to everyone. So now startups company can partner with Node Health, and we can publish for free in journals. We did our inaugural digital medicine conference in New York City just in December, and we had 250 people, mostly CIOs, but really what was very interesting, we had people with chief medical officers, chief nursing officers, CEOs, because just a CIO alone cannot move the needle. They need champions internally. And if they just say, this is a great innovative product, someone really has to implement into best clinical practice. So you have to align with chief population health, chief medical officers there. And these are our focus areas. And if you can see, one of the pivotal themes we have is to actually see, can we change the digital divide to a digital bridge using all these technologies? So that's one focus area, targeting underserved population. And there was a concern that patients may not be able to take it, and I'll give just one reference for that. 78% of homeless population in Connecticut has smartphones. 78% of homeless population in Connecticut. Our internal population, we have 98% of our commercial payer having smartphones internally. So you can actually make needle move. Of course, there'll be 10-20% patients who will not be engaged, but then you can engage their caregivers, right? You can engage their son or a daughter or family friend who may have a smartphone. The second focus area is how do we actually do at-risk contracts with payers more meaningfully, right? And the third is how do we enable trials? So we are like a site network of early innovation, and how do we work together through central IRB to fast-track the process? I want to thank all the collaborators who have worked with us in this fascinating journey over the last 5 years. Everything that I had learned before I had to relearn everything in the last 5 years because I was never trained on this app world. And really, I want to end at this note that digital medicine is medicine, right? And really want to put a shout out for NJIT, the Practice Transformation Network, which is really doing some wonderful job here in bringing technologies like this to New Jersey area. And just to give an example, I want to pay a tribute to Stephen Hawking, right? So one of the greatest thinkers of our time, right? It was technology which came into voice, and that voice we are still, hearing even after his death. So thank you very much. Are we done? Okay. So I've been told I have some time. I have 10 minutes. Oh, that's wonderful.
Any questions? And
Hey, Ashish, good job as usual. So tell us here, what do you think the number one thing is that participants can help with Node and its mission? Very practically, like a lot of folks probably just heard about it for the first time, while others have been participating for a while. But what are you looking from us?
Thank you. So our concept is you all become a node. I'm looking at NJIT actually to be the node for New Jersey, practice transformation. And for every node, there is a need from the node, and there's an asset in the node, right? So you have needs, and I was seeing the need by the JFK family practice, right? How do you actually support all this care transformation in a much more automated fashion than brute force, right? Maybe that's the need. So we really want to know what your needs are, and then you have an asset, right? So you have a patient population. So we can see what we have learned and see if we can work together on testing technologies which really can make a difference. So our ask is basically come to us or come to the New Jersey node and say, lay out your challenges. I would say 30-40% of the challenges would have probably been solved by someone in US. And our goal is to bring those things to you. And things which are not solved, we take it as challenges for Node Health and we try to solve it together. So you can just go to info@nodehealth.org or talk to Judith. If you are a health system or a practice, we can onboard you and start into our consortium. We have a bi-weekly consortium calls and a community channel. So we can engage with you so you can learn with everyone else and bring your ideas and bring your needs to us.